We've talked a little bit about some of the clinical psychology scales that are used in forensic assessment as well. Um, we're looking at a few more specific, they're called FAIs, forensic assessment instruments that are specifically developed for forensic assessment, designed to assess, right here, for specific legal or clinical issues such as insanity and competency. And competency hearings and sanity hearings, these are much more frequently used, and they do a really good job. Well, the best we can. Usually better suited than clinical psychology assessment instruments. Forensically relevant instruments, they're designed to focus on clinical issues such as risk of future violence and psychopathy. Some of the advantages, they're less removed from the immediate legal question. Example, the Rogers Clinical Responsibility Assessment Scales, RCRAS, would more directly assess the degree to which the defendant's ability was impaired in regard to legal charges she faced. Did this cause emotional disruption? Does this cause cognitive disruption that might impair that person's ability to take assessments appropriately? So they also assess that degree. When a person is facing charges emotionally, it causes issues for them at times, certain people. So we can also determine how much that's playing into the outcomes of the testing. Usage of test among forensic psychologists. Choosing a test, again, scope of practice, we have to determine, is it within our expertise? Have we administered this test multiple times? How much success in terms of accuracy, in terms of getting good results, have we had those opportunities? Meeting admissibility criteria, it has to be admissible in court. So is the certain test that we're using a type that is typically admissible, or if it's inadmissible or it's not going to be relevant to the specific forensic question at hand, then we need to maybe find a different test that would. Research on the clinical technique. What does research tell us? Is it reliable? Is it valid? Or is there some problems like projective testing and the reliability and validity? And the appropriateness of the test we're using. Again, back to the legal question, is it going to directly help answer that question? Archival third-party information, gathering records from outside, past histories of people, interviews outside the person being evaluated are like medical records, hospital records, their mental health records, employment records, school records, police arrest, history of any criminal charges or convictions. Also, greater reliance on forensic evaluations. It says a greater need for accuracy in forensic psychology evaluations is needed. High likelihood of secondary gain and increased likelihood of malingering as a result. Again, the term malingering, faking symptoms, faking mental illness, faking certain abilities. Can a test do a good job of confirming there is malingering or ruling out that this person is being forthright and not trying to fey or mislead us? Use of written reports and forensic assessments and guidelines, procedures used and basis for experts' conclusion, overall findings. Separate facts from inferences, a distinction between the conclusions and data upon which the conclusions are based. Stay within the scope of the referral question. Avoid extra comments, have little relevance to the referral question. Example, there would be the dangerousness of the defendant. Stay away from that. Again, a forensic psychologist making predictions is not something that's helpful. We want to give our professional opinion. We want to be very careful in making any predictions. Predictions often are very unpredictable, even with solid testing that we're using. Avoid information. Overkill, underkill. Give the right amount. Be concise. Don't give too much information. When you're sharing this information with the court, you're to give adequate, but not too much and not too little. And then answer the follow-up questions the same way. Not too much, not too little. Minimize clinical jargon. Communicate properly in the legal context. You want to be careful with throwing out a lot of DSM words, which we call them, or words that clinical psychologists are familiar with, but in a legal situation they might not. So you want to minimize that and be very clear and concise, and use layman's terms for clinical issues when necessary. So most frequently reported faults in the reports. Grisso in 2010 came up with 53% opinions without sufficient explanations that experts are giving. Forensic purpose is unclear, about 53% of the problems. Organizational problems with the information. Irrelevant data or opinions that are given, 31%. Failure to consider alternative hypothesis, 30%. Inadequate data to form opinion, about 28%. Data interpretation mixed in report, about 26% of that. Over-reliance on a single source of data. Want to have multiple solid sources. Language problems, jargon, bias, extraneous comments, improper use of tests. So you can see there's a lot of reported faults with the reports that experts make, that forensic psychologists provide. We want to make sure we kind of cover that. Treatment in forensic context, because forensic psychologists, after doing assessment work and giving their professional opinions, are then sometimes relied on to make treatment recommendations or even organize the treatment. They may share much in common with traditional psychological treatments, but also tied to the legal context at times. Correctional psychology is an area that we're focusing on when we're looking at treatment. So application of clinical psychology to prison or correctional settings. What types of recommendations do we make if they're going to be in a prison or correctional setting in terms of their access to psychological help? And should that be necessitated? Who are we treating? Mentally ill offenders, female offenders, substance abuse offenders, domestic violence perpetrators, sex offenders, violent offenders, general offenders. A whole host of people that we're treating and making treatment recommendations for as a clinical psychologist or as a forensic psychologist. Mental disorders in offenders, the rates of mental illness in offenders in the court cases that we see, about 5 to 50%, between 5 and 50% are mentally ill with these types of disorders. Antisocial personality disorder. Remember, antisocial means not pro-social, but out to manipulate, harm and hurt other people. Substance abuse, schizophrenia, bipolar, major depression, all within that 5 to 50%. The reasons, criminalization of the mentally ill, prison experience, and vulnerability of offenders are also areas that we look at when we're making recommendations, and we want to make sure that we're careful of these elements. And offenders, there's a vulnerability to them that we need to address and always make arrangements for helping when we can. Types of treatment, there's management. We reduce and eliminate acute crisis. Crisis management, we resolve the crisis quickly. Safety needs are met. Establish a plan to reduce future reoccurrences. Some of the examples that we would use crisis management would be self-mutilation, suicidal gestures, displays of psychotic or impulsive psychopathology, and then general violence and then trauma. Maintenance would be more offenders suffering from a serious mental illness, developmental disorder, a cognitive disorder. So stabilization through medication might be part of the maintenance protocol, or other type of help through a psychologist, counselors, therapist. Outpatient help, adjustment and coping problems, anxiety, depression that are results of daily living. Identify coping strategy, eliminate cognitive disorders, symptoms of symptom management. And we send them to outward or outpatient psychologists in private practice and local clinics. Then specialized programs for sexual offenders, chemical dependency, and personality disorders. Personality disorders are tough to crack, y'all. That is the one area of clinical psychology where we don't have a lot of success in helping people change. Antisocial personality disorder being one of them. They are tough to deal with. They're ingrained in the personality structure, which makes specialized programs for personality disorders difficult and not easy to treat. Success of offender programs, considerable enthusiasm for treatment programs in the 1950s and 1960s. Since the 70s, nothing works for you. They became a little burned out on anything really helping them. In recent years, reviews of literature have clarified success in treatment programs, believing that, yes, chemical dependency programs do work. Other types of programs can help. A growing body of research literature attests to the fact that some rehabilitation programs are successful with some offenders when applied by some staff. I know, 1994. It's hit and miss, y'all. There is some success, but it really depends on who, where, and how. it's kind of like if you're going to get help for depression and you go to 3 or 4 different psychologists, therapists, psychiatrists, one of those might be the right fit for you at the right location, offering the right type of options. Where the other one might have the experience and have helped people, but they're just not the right fit for you. So sometimes it's in finding that niche, that area where it's really going to be effective. Often, though, we send people to the wrong place and they get with the wrong people. Successful offender programs, sound conceptual model, risk needs responsivity, the RNR is good, targeting criminological needs, responsivity principle, factors important for mental health goals, mental illness, recovery, emotional management, institutional functioning, reentry, risk need, personal growth. All these areas are important to look at. And then consultation, need to be more mindful of ethical issues. Yeah, I mean, we're as a licensed professional clinician, I have to every 2 years to get 3 hours of workshop or professional continued education hours in ethics. And to be honest with you guys, it's the same kind of course every 2 years. They're starting to do a better job of offering certain ethical dilemmas, certain ethical areas, specific, like for instance, I'm a licensed marriage and family therapist, so ethics that apply to marriages and couples and working specifically with them, as opposed to ethics when working with children, ethics when working with offenders, et cetera, et cetera. Assist attorneys, referrals, evaluate work of other psychologists, work shaping policy, all these areas we do consultation in. And making the right kind of referrals to the right kind of people. When you're working in a community, you get to know the right attorneys, the right judges even, and you have working relationships with these people, and they're people that you trust. There's some that you don't, and you stay clear of them or you don't refer to them. Evaluating the work of other psychologists and helping them. We do a lot of peer work together. We try to consult with each other. We try to have good working relationships. It makes a difference.